Hello all, I am Dr. Harmeet Goel taking up the FMGE July 2023 OBG recall session, and whatever questions I have collected from the students, I have tried my best that those questions should exactly look like the way it has been asked in the exam. Hope you must have done your best in the exam. Let us just start the Obs Gynae recall session. You can keep on writing your answers in the chat box, or if there is any query, you can ask. Now, question number 1, what hormones are secreted by the Leydig cells and the Sertoli cells? All of you know that the Leydig cells and the Sertoli cells are present in the testis, and they start secreting the hormones in the intrauterine life around 7th week of pregnancy. Now, the Leydig cells have got receptors for LH, and Sertoli cells have receptors for FSH. This FSH and LH are called as follicular stimulating hormone, and LH is luteinizing hormone. So let us read the options given to me. The options are, and they are asking this question, that which is the hormones that are being secreted by the Leydig cells and Sertoli cells in the males. So the options given to me are DHA and testosterone, testosterone and inhibin, testosterone and DHA, inhibin and testosterone. So clearly I have been teaching this in my classes that testis or undifferentiated gonad at the 7th week of pregnancy starts secreting the hormones. Sertoli cells, they secrete Mullerian inhibiting substance which inhibits the development of Mullerian duct in the males, and Leydig cells secrete testosterone. Okay, so Leydig cells, this is in the intrauterine life, secrete testosterone. Testosterone is very important for the development of male internal genital organs. Male internal genital organs are seminal vesicles, epididymis, vas deferens and ejaculatory ducts, and this testosterone in the intrauterine life is also important for development of male external genitalia. This is in the intrauterine life. Now, what does Sertoli cells secrete at the time of puberty? Sertoli cells secrete the androgen binding protein, so that at the time of puberty, the testosterone which has been secreted by the Leydig cells should bind to this, and it will keep the testosterone levels high in the testis so that spermatogenesis can take place. Sertoli cells also secrete a inhibin hormone. So what are the hormones secreted by Sertoli cells is Mullerian inhibiting substance, androgen binding protein and inhibin. So answer to this question is Sertoli cells secrete inhibin and Leydig cells secrete testosterone. So the correct answer is inhibin, and the correct answer is the Leydig cells secrete testosterone. Leydig cells secrete testosterone and Sertoli cells secrete inhibin. So the correct answer is B. Leydig cells secrete testosterone and Sertoli cells secretes inhibin. Fine. Next. Total spermatogenesis is complete in how much time? This is again very important, and I want you to be ready for your next upcoming PG entrance exam. Those who have to finish their internship after finishing their FMG exam. So these questions are important for that also. Spermatogenesis is finished in 74 days. Now let us quickly switch over to the next question. Which of the following is a direct cause of maternal death? There are various students sending us the different answers, so I will be discussing from every point of view. Direct cause of maternal death. First of all, you have to know maternal death. Maternal death is occurring up to 42 days of delivery. So that is the definition of maternal deaths. Now, direct cause, embolism, heart disease, anemia are the medical causes, because it is not that embolism is only seen in pregnancy, or heart disease is only seen in pregnancy, or anemia occurs only in pregnancy. So embolism, heart disease, anemia, these are the medical causes, and if the disease is not being controlled, it can lead to death. So I am not going to consider these three as the direct causes of maternal death. So according to me, preeclampsia. Preeclampsia means blood pressure plus proteinuria developing after 20 weeks of pregnancy. So the term preeclampsia means the lady is normotensive in less than 20 weeks of pregnancy. At each antenatal visit, we do check the blood pressure. So when the blood pressure is raised after 20 weeks of pregnancy, plus there is proteinuria, that is by dipstick method we check it, and 2+ is taken as significant. Although to describe the severity of preeclampsia, proteinuria has not given any significance. It is the blood pressure and the end organ damage. Okay. So the answer to this question is preeclampsia. So I am going to take this session in very crisp and concise manner. Now, few questions I want you to just revise. Most common cause of maternal mortality in India is postpartum hemorrhage. That is highly preventable cause, and the drug that is recommended by WHO to prevent postpartum hemorrhage is injection oxytocin. Now, most common indirect cause of maternal mortality in India, you can keep on writing your answers in the chat box. The answer is anemia. A lady delivered a child and went into shock. So most important cause is postpartum hemorrhage. A lady delivered a child and went into shock, that is out of proportion of blood loss. The answer is acute inversion of uterus. So I am happy that most of you are being attentive in the session and you are writing. Good afternoon everybody. Dr. Hardik, Dr. Maj, Dr. Chahal, Dr. Mithu, Dr. Abhinav, Dr. Megha, Dr. Vivek, Dr. Inder, Dr. Garg. All of you are, very impressively writing all the correct answers to the questions which I am discussing. Now, this is interactive session. If you have any doubt, you can keep on writing in the chat box. I can read your chat box in front of me. Now, a lady delivered a child and went into unexplained shock. Always students remember, this is amniotic fluid embolism, and nowadays questions are very commonly asked in amniotic fluid embolism. So what I have heard is the clinical pattern, the students have given it very perfectly, but the pre and para clinicals are being asked in the integrated manner. Doesn't matter. The long questions are always easy. You get a lot of hints in the questions. Now, a lady delivered a child, started gasping, breathless, cyanosis and collapse. This has been asked in INI CET exam and it has been asked in FMG exam. All these are been clinical questions which they have asked in the previous exams. So the answer to the last point is again amniotic fluid embolism. Okay, next. A lady, this is my question number 3. A pregnant lady with 32 weeks of pregnancy with blood pressure 140/90, pedal edema and urine proteins by dipstick method is 2 plus. Urine proteins by dipstick method is 2 plus. So what is this category? I'm sure every one of you, different students are writing different answers. So I will be discussing from every point of view. You are the better judge because you have given the exam and you know what type of questions have been framed in the exam. So what is the answer to this question? I can read your answers. Dr. Mithu, Dr. Vivek, Dr. Shine, Dr. Inder, Dr. Meeta. So the correct answer to this question is preeclampsia, as I have already discussed in the previous part. Now the difference between preeclampsia and chronic hypertension. Basic thing is here there is blood pressure plus proteinuria developing after 20 weeks of pregnancy, whereas in chronic hypertension the blood pressure is present from the beginning of pregnancy and there is no proteinuria. Chronic hypertension, even after the delivery, the blood pressure does not come down to normal, whereas the blood pressure in cases of preeclampsia after the delivery, most of the cases comes down to normal. I want to add up something latest. I have already recorded this in my app also for Ellen, that first line antihypertensives used in pregnancy. The correct answers are labetalol, hydralazine and nifedipine. The latest recommendations are that these three antihypertensives are the one which are recommended as first line drug and they are safe. Yes. Signs of end organ damage, yes, that is a feature of severe preeclampsia. Fine. So what are the first line antihypertensives in pregnancy? Labetalol, which is alpha beta blocker, hydralazine, which is arteriolar dilator, and nifedipine, which is calcium channel blocker. In cases of hypertensive crisis, we prefer labetalol plus nifedipine or hydralazine because it can be given in the IV form. Fine. Next question. This is my question number 4. 21 weeks married pregnant female was diagnosed with fetal congenital malformation. The period of gestation is 21 weeks. At 21 weeks of pregnancy, the ultrasound has shown congenital malformations. How many doctors' opinion is required and whose consent is needed? This I have been discussing in my sessions. When there was a high yield question session or my YouTube sessions, I have already discussed this. I am sure you can write down the correct answers because this is an interactive session. I can read the answers, Dr. Mithu, Dr. Vivek, Dr. Meeta, Dr. Soumya, Dr. Tiwari. Okay. So, you have written that mother consent and opinion of 2 doctors. Yes, you are absolutely right. The correct answer is C. Okay. According to the latest MTP Amendment Act 2021, the MTP is legal and the upper limit has been increased to 24 weeks. Opinion of 1 doctor is enough if you're doing MTP up to 20 weeks. And opinion of 2 doctors is needed when MTP is done between 20 to 24 weeks. So in my question, the period of gestation given to me is 21 weeks and the MTP can be done on mother's consent. MTP can be done on mother's consent. Okay. So all of you have written the correct answers. Let me switch over to the next question. This is my question number 5. What is the other name for outlet forceps? You know, we apply outlet forceps nowadays, and the name of the outlet forceps is the Wrigley's forceps, because these are the short curved forceps without any axis traction device. These are short curved forceps without any axis traction device. Okay, and it is to be applied at outlet when the fetal head is visible in the perineum. Fetal head is visible in the perineum without separating the labia. Fetal head is visible in the perineum without separating the labia. That means the baby is at the level of outlet and crowning has already occurred. So this is the safest type of forceps. The answer to this question is A. But suppose if any other type of forceps is being asked, then what should be our answer? Okay, so for that reason I have just added up some of the images of Keelan forceps, Das forceps, Piper forceps. Although these forceps are no longer used. Okay, these are no longer used. Okay, so this axis traction device, which was the long curved forceps with axis traction device, was the Das forceps. It is not used. This Piper's forceps was used to deliver after coming head of breech. To deliver after coming head of breech. So this is again no longer preferred. And the third type of forceps is Keelan forceps. So that you can remember for the next exams you are going to write. Do not restrict yourself to MBBS. Add up a qualification to your name. We will all boost you up for your better career. So Keelan forceps was used in cases of deep transverse arrest. It is a rotational plus extraction forceps. So the outcome of the baby was poor. Hence, it has been replaced by cesarean section in case in occipito-posterior the deep transverse arrest occurs. So management for deep transverse arrest nowadays is LSCS. Deep transverse arrest is common in android pelvis. All these questions are important. Okay. So I'm sure you must have marked the correct answers. Next, question number 6. In which week the diabetic screening is done in the pregnant lady? So I have got different options from different students. Now, diabetic screening, we say that universal screening for diabetes is to be done in India, since the incidence of diabetes in India is high. Now, the latest guideline recommends the first antenatal visit you should do the diabetic screening, and you can repeat the test at 24 to 28 weeks of pregnancy. So you can, according to the DIPSI criteria, you give 75 grams of glucose and check the blood sugar levels, blood glucose levels after 2 hours, and the cutoff value, it should be less than 140 milligram per deciliter. This is normal. If the value comes out to be more than 140 but less than 199 milligram per deciliter, this is, like gestational diabetes. Okay. And if the value comes out to be more than 200 milligram per deciliter, then this is pre-gestational diabetes. Now, if the first antenatal visit is not given, and according to the FOGSI criteria, all the pregnant ladies should be screened according to this question, 24 to 28 weeks of pregnancy. If there's a family history, I would say first antenatal visit, you do first screening test and repeat the test at 24 to 28 weeks of pregnancy. Why 24 to 28 weeks of pregnancy? Because at 24 to 28 weeks of pregnancy, the insulin resistance is high in pregnancy. Is high in pregnancy due to certain hormones like HPL, like progesterone, like cortisol. These are the hormones where there is increased insulin resistance. So the most sensitive time to do testing for diabetes is 24 to 28 weeks of pregnancy. Okay, if first antenatal visit was present in pregnancy, latest guideline says that you should be doing the test in first antenatal visit. That is our national guidelines, and you should repeat the test at 24 to 28 weeks of pregnancy. Okay. Question was pregnant lady with family history of diabetes and option had first visit. If the option says first ANC visit with family history of diabetes, I am going to mark this answer. If that is not given in the option, then the answer goes for 24 to 28 weeks. Dr. Ali, the questions which were given to me, the options were this. Okay. So, that is why the discussion is important. If the first antenatal visit was given and there's a family history of diabetes, I said I am going to mark first antenatal visit as my answer. If that is not given in the option, then I am going to mark 24 to 28 weeks of pregnancy. Detailed discussion of universal screening according to our national guidelines is first screening should be done at first antenatal visit and you should repeat at 24 to 28 weeks of pregnancy. So Dr. Ali, Dr. Pillai, Dr. Gupta, both ways I have discussed the question. So you are the better judge. If first antenatal visit with a family history of diabetes was given, then that should be the answer. Next. This is my question number 7. We can extend the MTP beyond 24 weeks in what condition? Okay. The upper limit for MTP legal is 24 weeks. Okay, MTP should be done according to the latest guidelines in less than 24 weeks. Students, you should be satisfied because both ways I am discussing the question because different set of students are sending us the different questions. So I have already discussed. Yes, Dr. Ali, I appreciate your comments. Yes, you have got it. Very correct. Okay. So I have already clarified. Now, in which condition? Is it rape? Is it contraceptive failure? Is it fetal malformation or is it a minor? In all these cases, MTP is allowed till 24 weeks. But in case of rape, if the pregnancy was unnoticed and in that case, in the rape victim, the pregnancy has crossed beyond 24 weeks, what we have to do is, now according to the latest MTP guidelines, there is a special medical board. There is a special medical board and this case will be taken up in special medical board which consists of a gynecologist, pediatrician, a radiologist and a gazetted officer appointed by state, government or union territory. So this case will be taken up by the special medical board and their opinion is the final opinion. If they say MTP has to be done, it should be done. Now, why there was Amendment Act after 1971? Because there were certain cases like rape victim, etc., where the pregnancy is going beyond 24 weeks, there was in the Indian law, there was no provision for doing MTP in that case. But nowadays there is amendment needed. So this case should be taken up. Yes, we can do in this case for that. Contraceptive failure is always a first trimester MTP indication. But in these cases, we can do MTP till 24 weeks. According to this option, I am going to select rape victim as the answer. Now, next question. In which of the following condition induction of labor is not done? This is a very, very straightforward question. Induction of labor is not done in which of the following condition? Is it oligohydramnios? Is it central placenta previa? Is it hypertension? Or is it premature rupture of fetal membranes? Premature rupture of fetal membranes. So what is the answer that you have marked? Yes. The correct answer to this question, is central placenta previa. For central placenta previa, you have to do an elective cesarean section. For central placenta previa, you have to do a planned cesarean section at 38 weeks. So I'm sure every one of you have marked it very, very correctly. So the answer is central placenta previa, where in case of oligohydramnios, hypertension in pregnancy and premature rupture of membranes, you can always do augmentation of labor or induction of labor. Now, question number 9. Hyperestrogenic condition are all of the following except. Now, hyperestrogenic condition. Okay. Tamoxifen use, endometriosis, ovarian cancer, all this. Tamoxifen is an anti-cancer drug used for breast cancer, but as a side effect, it causes endometrial cancer because the reason is it is acting as an estrogen antagonist. Estrogen antagonist on breast tissue, but it acts as estrogen agonist on endometrium. So raises the risk for endometrial cancer. Endometriosis is also a hyperestrogenic state. Ovarian cancer, like endometrioid cancer, is associated with the endometrial cancer, endometrioid adenocarcinoma, and moreover, hyperestrogenic state is a polycystic ovarian disease, and if there is multiple ovulation being done, the risk of epithelial ovarian tumor is increased. So answer to this question is B, low BMI. Okay, low BMI, I hope every one of you will agree with me. Low BMI is the answer to this question, because if the patient is in normal weight or normal BMI or low BMI, then the androgen levels, the fat is less, so androgens are less. Whereas in cases of obese females, the fat is high, so fat produces androgens, and from androgens, there is estrogen production. So hence, obesity is a risk factor for endometrial cancer. Obesity, diabetes, hypertension. This is a risk factor for endometrial cancer. I hope this is clear to you. Now, question number 10. How many weeks of gestation age the uterus will correspond to the post-delivery? This is very, very simple question. So the answer to this question is 20 weeks, because after the delivery, so umbilicus level is lower border 20 weeks, middle 22, above 24 weeks. After the and symphysis pubis was 12 weeks, Xiphi sternum was 36 weeks. Now, after the delivery has occurred, the uterus will come down to the umbilicus level, so it will correspond to 20 weeks of pregnancy. Next question. Pregnant women at 32 weeks of pregnancy comes to the emergency with severe abdominal pain and bleeding, and the uterus was tender and fetal heart rate is absent. Some of the students have given me the option. It was fetus. In the question, it was fetus not palpable. But the hint in the question was severe bleeding. Hint number 1. Number 2, the main important hint in this question was tender uterus. So which condition do you get? Severe pain abdomen, tender uterus, fetal heart rate may not be localized, or fetus not palpable. This is purely abruptio placentae. Now they wanted to confuse you between rupture uterus and abruptio placentae, but if your preparation is logical manner, then all of you must have marked your answer as abruptio placentae, even if the blood pressure is not given. Till in the previous exam, they were mentioning the blood pressure as 150 by 100. So that is preeclampsia or pregnancy-induced hypertension. And very important complication occurring in a preeclampsia patient in the antenatal period is abruptio placentae. Because of vasoconstriction of the umbilical cord, there is premature separation of placenta and leading to the formation of retroplacental clot. Now, why the fetus is not palpable? It is not rupture uterus. It is that there is premature separation of the placenta that has taken place, and there is formation of retroplacental clot, and if there is a blood collection in the uterus, that gives a tender swelling. If there is so much of the blood collected in the uterus, then you may not be able to palpate the fetal parts very easily, plus fetal heart rate, it will be difficult for you to localize. Blood pressure was falling. Even then, it is a case of abruptio placentae, because it cannot be rupture uterus unless until there is something written as in the question grand multipara or previous LSCS case and next pregnancy or previous classical cesarean scar or myomectomy scar. Nothing such history is written in this question. So, I am going to mark abruptio placentae as my answer. Now, question number 12. Question number 12. Nowadays, they have started asking question from so many topics, and Obs-Gynae is very scoring subject. Okay, you can easily score marks in this subject. I had been telling in my sessions, and most of you are writing your wonderful options. Okay, yes, Dr. Ali, you are writing everything correctly. I can read your comments in the chat box. Yes, Dr. Tiwari, you have also written very correctly. The option is, answer is B, that is abruptio placentae. Now, 3 swab test. 3 swab test is done for urinary fistulae, and this is also called as Jones dye test. And which dye you fill in the urinary bladder? Suppose this is the urinary bladder. So, you fill a methylene blue dye. This is methylene blue dye. And in the vagina, you keep 3 cotton swabs. 3 cotton swabs, number 1, number 2, and number 3. Now, they said middle swab is stained of the dye. Now, let us see the options. Uretrovaginal fistula, vesicovaginal fistula, urethrovaginal fistula, uretrovaginal fistula. There is no term like that. Okay, it must be something else which is written in the option. So, uretrovaginal, vesicovaginal, urethrovaginal fistula, 3 swabs. After the urinary bladder has been filled with the methylene blue dye, 3 swabs are kept in the vagina. Now, after some time, you look at the swab. If suppose first swab is wet, is not stained but wet, smelling of urine, then that is uretrovaginal vaginal fistula. If blue second swab is blue, then it is vesico-vaginal fistula. In this question, they have asked about the middle swab. So the answer to this question is vesico-vaginal fistula, VVF. Okay. Now, if the third swab is stained blue, for example, then it is urethro-vaginal fistula. If it is stained blue. So this is Jones 3 swab test. Nowadays, VVF, most common cause of VVF in countries like India is obstructed labor, and you repair it after 3 months. Most common cause of vesico-vaginal fistula in Western countries is gynecological operations like Wardheim's hysterectomy, gynae surgeries like Wardheim's hysterectomy. But in a country like India or developing countries like India, most common cause of vesico-vaginal fistula is obstructed labor, and the symptom is true incontinence of urine or continuous dribbling of urine from vagina. The investigation done for vesico-vaginal fistula is cystoscopy, and for ureteric fistula you can go for IVP. Next, this is question number 13. Hormone in molar pregnancy. Few students have given me this option: GnRH, FSH, HCG or LH. Always in the molar pregnancies or trophoblastic diseases or trophoblastic tumors, the features are happening because the trophoblastic tissue secretes the HCG, and the features of thyrotoxicosis, pregnancy-induced hypertension or hyperemesis is caused by HCG. So the correct answer to this question is HCG. Okay. Another set of students have given me question like this: molar pregnancy is usually diagnosed in early pregnancy due to bleeding and abnormal features of ultrasound higher than usual levels of the what are the hormonal levels. So again, according to this, it is HCG, and ultrasound is the investigation of choice. And what do you see in this image is snow storm appearance. For me, all the students are important. So whichever is the format of question, the answer here is HCG. Okay. So whether this way the question was asked or this way the question was asked. Now, question number 13. Identify this anomaly. So this is actually not very commonly which we see in the obstetrics. This is a specimen. It is not anencephaly. It is anencephaly craniorachistisis. So that is the answer. So for more details, sometimes एक या दो question थोड़ा हटके भी पूछ लेते हैं. So for that reason, this you should, I think, for the malformations, it's better that you should be reading this in embryology part. Okay. Okay, in the first paper, Dr. Ali is saying the vesicular mole was given. So I am okay with that, because I have told you that this is the correct answer to this question. So question number 14. Identify this maneuver. So when I have taken up the topic of normal labor, I have already shown you this image, or even the image based session which I have taken up. So this image I had already added. So this is not Lofset's, this is not Morrissey-Smiley V8, this is not Pinard's maneuver. Pinard's, Lofset's and Morrissey-Smiley V8, all that are done for breech. This is for breech. Morrissey-Smiley V8 technique is for breech. This Ridgen maneuver, answer is C. It is done in cases of you are conducting a vaginal delivery. In this case, one hand is put. So this image is a Ridgen maneuver. When you are conducting the vaginal delivery, One hand is onto the chin of the baby and another hand is on the occiput of the baby, and you conduct the delivery of the head towards the mother's abdomen. This way to avoid any perineal tear. Okay. Okay. If image was not asked in this question, Dr. Ali is writing like maneuver done to deliver the fetal head. So maneuver done to deliver the fetal head, then it is again a Ridgen maneuver. Okay, Ridgen maneuver. So you can just go through the image so that you can easily remember this. Now what is Pinard's maneuver, Lofset's maneuver, Morrissey, Smiley-Viet technique? This maneuver is a Lofset's maneuver for delivering the breech with extended arm. Okay. Now this maneuver is a Pinard's maneuver. This is to deliver breech with extended leg. And this maneuver is Morrissey Smiley-Viet technique to deliver after coming head of breech. After coming head of breech. So I hope this answer is clear to you, and other images are being added so that you can easily understand or remember the other options. This is very clear-cut image even if the options are not being provided to me. This is Viry's needle and this is used to create pneumoperitoneum in cases of laparoscopy. Whether laparoscopy you are doing for diagnostic purpose or you are doing for therapeutic purpose. Now, carbon dioxide is the gas used to create a pneumoperitoneum. Since all of you know this, so I am not going into very details of this. Now, question number 16. Which is not used as an emergency contraception? So, emergency contraception, I have always discussed. Emergency contraception is a post-coital contraception. It is hormonal, which is to be given within 72 hours of unprotected coitus, and it can be IUCD to be inserted within 5 days of unprotected coitus, and only IUCD that we can insert is the copper T. Now among the hormonal, it is LNG pill which is most commonly used, and it is single dose, that is 1.25 milligram single dose. Number 2 is OCPs, that is 4 tablets after a gap of 12 hours, 4 tablets. And third one is RU486. Nowadays, even ulipristal is being used as 30 milligram single dose within 5 days of unprotected coitus. Okay. So, let us read the options. Ulipristal 30 milligram, this is used. LNG 7.75 and 2 divided doses. No, this is wrong answer. So, the answer to our question is B. Since levonorgestrel 1.5 milligram single tablet is the one which is most commonly used in a country like India. Okay. No, Dr. Singh and Dr. Kumar, the answer is not A, answer is B. Because levonorgestrel 1.5 milligram single dose has been used. It is not given at divided doses after 24 hours interval. So if you have to give it in 2 doses, then it is 12 hours apart, otherwise the contraception will not be effective. So which is the most commonly used emergency contraception in India, whether it is married or unmarried female? So the correct answer is LNG pill 1.25 milligram single dose. Which is the best emergency contraception? Answer is copper T. Okay. Ulipristal is used in other countries. The dose is 30 milligram to be given within 5 days of unprotected coitus, and it is progesterone receptor modulator. Progesterone receptor modulator. It has only two uses. One is as a post-coital contraception and another one is fibroid uterus. Okay. So, next question. Question number 17. Drug used for chemoradiation in cervical cancer. All of you know the answer is cisplatin. Okay. So, the most commonly used drug as a radiosensitizer, chemotherapeutic drug which is used as radiosensitizer is cisplatin. This is clear cut and straightforward question. Next, question number 18. In which trimester beta-HCG, unconjugated estriol, alpha-fetoproteins and inhibin test is done in the antenatal screening? One set of students have sent me this question, and another set of students have sent me a question that quadruple test is done in which trimester of pregnancy. So quadruple test is done in the second trimester of pregnancy and the timing is 16 to 18 weeks. The markers are alpha fetoproteins, beta HCG, estriol and inhibin A. Alpha fetoproteins are decreased, beta HCG rises, estriol decreases, inhibin A rises. This is for trisomy 21. In the first trimester, you do beta HCG, which is increased, and you do PAPA, pregnancy associated plasma protein, which is decreased. In the second trimester, you do triple test, but nowadays, triple test has been replaced by quadruple test. Okay? Quadruple test. Fine. So, I'm sure you must have done this question also correct. Question number 19. On 5th postpartum day. So, here you get your answer. 5th postpartum day, women presents with low mood, sadness, irritability, crying, restlessness, depression and reduced sleep. This is most of the time self-limiting. Self-limiting. And what I have read in obstetrics, even my post-graduation time, some of the patients we used to get like this. And the answer to this question is postpartum blue. And my colleague from psychiatry will be the better person to tell you the details of this question. So it is postpartum blues. Wherever 5th postpartum day is written, sadness, irritability, crying, depression, the answer is usually postpartum blues. Next question, question number 20. Women with postpartum hemorrhage was treated with ergometrin, okay, and oxytocin. Still, the bleeding has not stopped. Which prostaglandin derivative should be used? So, first line drug is oxytocin. Then you can use ergometrin, okay. Then if the bleeding is not been stopped, then we use prostaglandin E1, that is misoprostol tablet, and we use it by 800 micrograms sublingual route. Vaginal route is not preferred because it is postpartum hemorrhage occurring, so it will be washed out. Okay. So I'm sure you are knowing the best answer. Dinoprost is prostaglandin E2 gel that is used for induction of labor. Carboprost is prostaglandin F2 alpha that can also be used. But if you go by the guidelines, misoprostol is the one which is preferred over the carboprost. Now question number 21. When is the suction evacuation done? So suction evacuation is a method for first trimester MTP. So the correct answer to this question is 12 weeks. Because why I am not choosing the 6 weeks as my answer? Because up to how many weeks of pregnancy suction evacuation can be done as a method of MTP? So the answer is 12 weeks. Even suction evacuation is being done for H-molar pregnancy evacuation in young female. Okay. What is the most common complication of suction evacuation method? Answer is always bleeding due to incomplete evacuation. Number 2, what is the suction evacuation pressure? Answer is 400 to 600 millimeters of mercury. So this topic is again very important for questions. Now next is question number 22. 47xxy, what is the wrong statement? What is 47xxy? Can you mark your can you write down in the options what have you marked? What is 47xxy? Can you type in the chat box? Dr. Vivek, Dr. Sujata, Dr. Shogun, Dr. Pillai, Dr. Ali. Klinefelter syndrome. In Klinefelter syndrome, they are tall males with gynecomastia, hypogonadism, and male infertility. They have extra X chromosome, so they have sex chromatin is present in them. Okay, so when there is hypogonadism, so FSH will be decreased. If FSH is decreased, that is why they are infertile, because spermatogenesis will be affected in this case. They are azoospermic, correct, decreased testicular size, hyalinization of Sertoli cells, all these three are correct. Wrong answer is decreased FSH. They are having increased FSH. So the answer to this question is A, decreased FSH. I hope it is clear to you. Yes, all of you are writing Klinefelter syndrome as the correct answer. Now next is question number 23. Male had infertility and respiratory infection. Respiratory infection and infertility, this is Carter-Jenner syndrome. And in Carter-Jenner syndrome, the male has frequent respiratory infections and infertility. It is autosomal recessive disorder. So ciliary dyskinesia is the answer. Ciliary dyskinesia, because this is Carter-Jenner syndrome. Details you must have read in the pathology. Next question. Question number 24. A girl with PCOS, and what type of test is to be done? So options given to me by the students are sleep study, urine study, FSH, and serum testosterone. Well, I don't understand the urine study here or the sleep study, whether they want to ask about the okay, I don't know, the students have told me, but if you take it as what is the most commonly done investigation in PCOS patient, so the answer is we check the hormonal profile where there is FSH-LH ratio, E2 to E1 ratio, fasting insulin, and the first investigation we do it is serum testosterone levels. Serum testosterone levels. Fine. So if this question is written, yes, you are writing, Dr. Tiwari, correct one. But if I take up this question, first test to be done to differentiate, like PCOS from congenital adrenal hyperplasia or late onset, or from the virilizing ovarian tumors, serum testosterone is the one which is done. Other investigations include LH-FSH ratio. So serum testosterone in this case is more than 70 nanogram per ml, but less than 200 nanogram per ml. So that is PCOS. LH to FSH ratio is increased. Then E2 to E1 ratio is also, decreased. And there is fasting insulin levels which is done, which is elevated, plus LH is also elevated, and inhibin is also elevated. Okay. So details you must have studied in the preparation time. Now next one, question number 25. McCall's scaldoplasty is done in Meckel's scaldoplasty is done for enterocele repair. So it is Meckel's scaldoplasty or Moskowitz repair. These are the two surgeries which are done for enterocele. For rectocele, the surgery is posterior colpoperineoplasty. Okay. So urethrocoele is like repaired along with cystocele, and the surgery is anterior colporrhaphy. For vault prolapse, there are various surgeries like colpopexy, etc. Okay. So that's all from this discussion session. This question number 26, which has been given to me, but I would say this is a more of a question of dermat. So according to this image provided to me, it appears to me as condyloma acuminata, and the cause is HPV 611. Okay. Yes, I am considering all the comments, Dr. Ali, regarding the previous question. Okay. See, I have discussed the question of PCOS like the investigation which is to be done, then answer is testosterone. If they have asked least to mark, okay, whatever you are framing the question, according to what the correct option, the students know it better because they have given the paper. So what was the exact language of the question? Uh, so like you have confidence in yourself because the questions given to us, according to that question and options provided to us, we are taking this discussion. So hope this session was useful to you, and like I switch over this like to the other faculties for the discussion of other subjects. So all the best. Hope, sincerely hoping that all of you will come up as winners. Thank you for this session.